welcome to Pilates Elephants. I'm Raphael Bender. Today we're going to examine the question, does movement need to change in order to change pain? And when I say we, it's not the royal we. Today I'm here with Dr. Kevin Wernli. Welcome, Kevin.
Thanks, Ralph. Thanks for having me.
So, dear listener, Kevin's a PhD physiotherapist. You're a lecturer at Curtin University in WA, right?
Yes.
Yep. And also, do you still work at Body Logic with Peter O'Sullivan?
No, I worked there for 5 years. I'm now working at West Coast Health and High Performance, which is at the Eagles training facility, the West Coast Eagles training facility.
All right. So can you give us, after that somewhat accurate introduction by me, can you give us, the brief overview of who you are and your professional interest in the area we're going to discuss?
Sure. Thanks, Ralph. Yes, I'm a physio by trade. I'd say that's my primary identity. I have always had an interest in low back pain and movement and posture, and I think low back pain is such a big problem that we can do a lot as sort of health professionals to help improve. And that led to a series of sliding door moments, but eventually I did a course with Peter O'Sullivan over in Brisbane on cognitive functional therapy, and a long story short, ended up doing a PhD with him over back in Perth. I'm from Perth originally. So I spend my time's quite split, I suppose. I spend a bit of time in the clinic, sort of 3 days a week, working clinically and seeing patients, predominantly people with disabling chronic complex health conditions or pain conditions, and that's a lot of workers' comp patients, but also just your people off the street as well. So I have that kind of clinical load. I then do some, as you mentioned, some sessional teaching at Curtin. This semester was on the management of pain unit. For the undergrads, I've got a PhD student I supervise or co-supervise. I'm quite interested in using technology to help improve the effectiveness and the efficacy of healthcare. So I have done a number of podcasts and research translation, and I'm the co-founder of a digital health platform helping people with endometriosis optimize their care before and after surgery called Matilda Health. So I kind of dip my toes through a variety of different areas to try and figure out where I feel like I can have the biggest impact. So yeah, I'd say that sort of most accurately, I think, summarizes me.
Okay. Well, I'm hoping we can make use of a lot of that breadth today, because the reason I reached out to you to come on the podcast was your paper. And I'm not sure, maybe this was part of your PhD thesis.
It was, yeah.
Does movement change when low back pain changes? A systematic review. It's from 2020 now, which shocks me to think that that's 4 years ago, almost 5 years ago now.
Yeah, me too.
I quote that, or cite that in my in one of the courses that I teach pretty regularly, and along with a couple of other papers actually that you cite in there, the is a positive clinical outcome. The Steiger paper from 2010 or 2012 or whenever it was, which basically looked at when people did exercise for low back pain, did it matter whether they actually got stronger or more mobile or better endurance or whatever? And the short answer was no, it didn't. So strength exercise helps low back pain, but it doesn't matter if you get stronger or not. Endurance exercise helps low back pain. Doesn't matter if you improve your endurance. Stretching helps low back pain. Doesn't matter if you get more flexible.
Exactly.
And so your literature review really builds on that because you looked at, which I found fascinating, the individual level data rather than the group data. And this gets at something which a lot of people is a criticism of this field of research a lot, which people say, oh, well, that's on average, it doesn't seem to work, but, for this specific person, it was really important. So can you just give us like a brief summary of like what you were trying to understand with this study?
Yeah, so as you say, that was the first published paper from my PhD. There's sort of 4 maybe that we'll kind of bounce around and discuss potentially in the conversation today. And you're right, it was I suppose a bit more of an in-depth view on the Steiger paper, but also and what I mean by that, we also looked at also movement velocity as well as muscle activity. So they just looked at range of motion, endurance, and strength. Whereas we looked at a few more we really wanted to hone in on this question around movement. Initially, we looked at posture as well, and it was just way too big. So we had to narrow it down to look at specifically at movement. And the reason we did this, I think, is health professionals, as people with pain, as society, we have this overall belief that movement and posture, but particularly movement, is important in the prevention of back pain, in the treatment of back pain, in who's more likely to get back pain or not. And I think it's kind of this kind of foundational thing that health professionals assess. We teach people to assess it, and then we treat it. And we expect that when we treat it, it improves. And that's, quite a common belief. And then when we looked at the literature, we sort of found these papers and not really much since. And we wanted to understand that at a deeper level. So if people actually improved from their back pain perspective, what actually happened to the movement? And we actually found that quite often, it was one of the most common reasons we excluded studies, people didn't follow it, remeasure the movement at the second time period. So they might measure at the start, do the intervention, that people get better. Yep, no worries, but they don't actually remeasure movement. So we can't actually know whether that improvement was related to a change in their movement. And the point you make about averages, I think, was another kind of theme throughout my PhD, was really trying to understand stuff from an individual level perspective. As you say, I think people get quite hung up on the time. Well, that's just on average, and my patient improves, and that's all true, of course. But we need the data to sort of support that as well. And I think the easiest way to sort of examine that relationship is, on average, we might see that a group of people gets a little bit better, but within that, there might be some people that get a whole lot better and some people that don't get better. And if we haven't quite measured the right things, or measured the number of those things to help understand, well, what's the difference between those that do get better and those that don't get better, then we can't really understand the kind of the mechanisms, or get a little bit of more of an understanding around some of the causality questions, or why. I suppose the big question is the why question. So when we look at individual level data, we can see things that relate much more from that individual person. So we looked at if this one person's change in movement was related to that individual's change in pain or activity limitation, and kind of averaged that over, it was quite complex. It's hard to explain simply, average that across the whole population. So we needed individual level data for each of these studies, not just an average, I suppose.
Yeah, and this is interesting because, like you say, pretty much, we must have hundreds of thousands of trials on exercise for low back pain at this point, and basically they all show that everything works a little bit and nothing works spectacularly.
Yep.
And it's mind-blowing to me that the majority of these trials don't actually correlate the change in the physical sort of intervention parameter that they're targeting. Like, does your scapula, or I guess if we're talking about low back pain, does your muscle activation increase? Does your posture improve? Does your core strength increase, or whatever? And then correlate that with, does your pain decrease and function improve? It makes me think about like another study that I'm sure you're familiar with is the Mannion one from 2012, where they looked at spine stabilization exercises in the treatment of low back pain, and they found that, guess what? Yes, they help a bit. On average, about the same as anything else. But then they looked at, like you said, people in the study who did really well, and then people who didn't do well at all. And then they looked at people who, in terms of their pain, and then they looked at who improved their muscle activation and really a lot, and who didn't. And it's like there was zero correlation between those.
Yeah, exactly. Yeah. Yeah, and I think that was kind of a common theme throughout the whole PhD write-up, was that we have all these disparate interventions, like you say, and sometimes quite opposite interventions, things that say, we need to increase flexion, and others that say we need to increase extension, and some say we need to relax more, and some say we need to tense more. But when you look at the effects on pain and function, they all kind of work a little bit, and particularly during that intervention period, and then they have this sort of drop-off phase where the intervention doesn't seem to sustain. And I think that speaks to sort of, the complexity of how humans have pain and how their pain improves, but also the kind of the variety of different ways that people can get better. And it probably speaks to a bit more of a common mechanism that I think in Mannion's paper she talked about this as well, was that maybe it's this sort of experience of doing something that's a little bit threatening and not having undue harm, or sort of this unintended or unpleasant expected pain with it. And then the nervous system kind of recalibrating, oh, that must mean this movement's safety is safe again, and therefore it doesn't produce pain. I think we're kind of getting into a little bit more of the way that the system produces pain now. But I think that's sort of this common thread or theme that I see in terms of why people get better. I think it's partly because that they have a positive experience doing something that they previously didn't feel confident doing or had pain doing.
Yeah, and we're right in the midst of this, I guess, transition from the biomedical model into the biopsychosocial model of pain. And, we've been in this transition for the last 40 years or so. So we're not exactly speeding through it.
No.
And of course, the biomedical model or the biomechanical model sort of poses that the body's a machine of cogs and levers, and when we have pain, it's because there's a problem with the cogs and levers. Something's out of alignment. Something's not turning properly, and therefore, if we can only use our clinical reasoning to figure out which cog is not turning properly, we can make a correction to the left foot, and all of a sudden, the low back pain's gone. And whereas the biopsychosocial model says, maybe biomechanics is part of it, maybe tissue is part of it, but there's also thoughts, emotions, context, beliefs, history, experience, and other parts of physiology, right? So like central nervous system, wind up, inflammation, other things. So, I guess, with that as a backdrop, how do you conceptualize, or how would you explain the current understanding of non-specific, chronic low back pain? And why is it so, if you go to Google Scholar and type in exercise for low back pain, there's literally 2 million plus results, right? And yet everything still has about a 0.3 effect size, which is like what they'd call modest, So why is it so, what's our current understanding of non-specific low back pain, and why is it so difficult to treat, do you think?
Yeah, I think, and just to riff off something we sort of mentioned before, I think these kind of movement flaws, and people can get better from them. And then we have this thing called confirmation bias, where we see that people get better because of XYZ thing that we've done, and we think, oh, it's because of the XYZ thing that I've done. But we've got to also understand that we're only seeing a small percentage of the population. And then when we do these broader, I guess, population studies, we see lots of people have this XYZ thing fault, or, quote unquote fault, biomechanical fault. And yes, that might be part of the person's story. And certainly if they believe it's part of the story and you help support them and graduate them back to meaningful tasks in a way that helps them achieve their valued goals, then of course that you can quite easily fall into this sort of understanding that, oh yeah, that must be because of this. But actually it might be a complex interplay between all those different factors that you kind of alluded to. If I look broadly at non-specific low back pain and where we're at, I think, as you say, there's certainly a shift towards a biopsychosocial model of care. I think we need to make sure the pendulum probably doesn't swing too far, and we certainly, I think, our first job as health professionals is to rule out any significant or serious pathology. Now, while that is rare, it's kind of 5 to 10%. It is important that we keep our understandings of that. From a, I suppose, mechanistic perspective, all our thoughts, emotions, the psychosocial factors all influence our nervous system and our pain system through biology, through neurotransmitters, and through all these sorts of things. So I don't think we can't forget about the bio and the biopsychosocial. But yeah, I think if we kind of summarize non-specific low back pain, it sort of suggests in the name that there is something that sometimes it can be specific, and that's that 5 to 10% that I mentioned before. I think broadly, if we just take a bit of a step back, we know that it's incredibly common. 80% of us will have back pain in our lives. It's the second most common reason people visit their GP. 1 in 6 people in Australia report back pains. It's a top 5 reasons people visit ED as well, and it's a leading cause of disability worldwide. But most of us will get better. Most of us will have this episode, but most of us, about 75% of us, will get better. So it's the 25% of us that end up being stuck or having an issue. So back to kind of non-specific low back pain. I guess it kind of all it means really is that we can't be certain with any sort of specific test or diagnostic procedure of that there is that one cause of pain. It doesn't mean the pain's not real. It doesn't mean we can't necessarily have hunches or suspicions on what's the dominant driver for this person. But it effectively means that there's no reliable or consistent reason or diagnosis that this person sort of falls into. And like we've talked about, I think that speaks to a variety of different factors that can therefore contribute to that person's pain. The way that they're thinking, the way that they're moving, how much load they've had on their body, how much sleep they're getting, what are they thinking about their back, what's happening at a local tissue level, what's happening at a more global tissue level in their system. What are the ways that they've been conditioned to that pain means or doesn't mean? What are the meanings of pain that they've been conditioned for as they grow up? It's I think a complex process. I think in society we've got these traditionally quite negative narratives around low back pain, which probably doesn't help. If we break pain down to what it is, it's this process that the nervous system produces when we've got credible evidence of actual or potential tissue damage. And if we have all these negatives around or negative messages around, if you've got back pain, you're going to have it for the rest of your life. And Uncle Bill had back pain and he had to have surgery and he had to stop working. And I'll be careful with your back. And you see all these signs around all the manual handling kind of pictures that say make sure you lift with a straight back. We have this sort of negative belief around back pain generally, I think. And I think that sets or primes the nervous system. And it is this really central thing. And, I've had episodes of back pain. Most people have, and it's this sort of central thing. When you've got hand pain, you can kind of use your other hand and still live and move quite well. But when you've got back pain, it's got this really debilitating sort of central effects. Everything you do, breathing, rolling, getting out of bed, working, sitting, standing, lifting. It's quite this sort of central thing. And then you combine that with the negative messages in society. And I think it creates this really high threat narrative or high danger narrative, which then paradoxically increases the want for the nervous system to protect. And then that ends up causing more intense experiences of pain as well.
And what if you go along to a well-meaning health or movement professional and then they say, make sure you keep safe in this exercise.
Yep.
Don't bend.
Yeah. Yep. Absolutely. Or be careful, or, I'll just be careful at the moment, or if something's painful, let's change that exercise and let's do something else, which again, I think is, we're health professionals. We don't want to inflict pain on our patients. We're caring people. And I think often the easiest thing to do is to just change the exercise. And I think, that's quite warranted and in lots of the cases, but I think we need to be a little bit mindful of always avoiding things, especially if they're linked with valuable and meaning tasks. I think avoidance is good if you've got a acute traumatic injury like a fracture or a broken bone or obviously is a fracture, some sort of serious pathology where you've had an overload, where your tissue tolerance has been overloaded, then absolutely it makes sense to avoid that, but for a period of time. And there was cases, we did qualitative interviews with people in my PhD. There was cases where people I've hurt my back 5 years ago and that's why I've still got pain and I still don't do all these sorts of things. So 5 years obviously is way longer than the kind of well documented time it takes for tissue to heal. So stuff that's lasting longer than 3-ish months, you're starting to think, okay, there might be some other stuff going on that's driving this person's pain, or at least strongly contributing to this person's pain. So if you hear those messages from a health professional, again, well-meaning, then that can really drive and result in these quite unhelpful thoughts, beliefs, emotions, and inevitably protective or patterns of behaviour that are quite common sense, but often quite unhelpful. And we found that in the qualitative research as well, was a lot of these people got their messages from searching online, but also health professionals.
From health professionals, yeah. I want to just double click on something you said there in relation to the non-specific and specific back pain. So when you say, 90, 95% of back pain can't be attributed to some specific cause in the tissues of the back. I think in the Pilates world anyway, there's a lot of, um, I guess, a lot of people aren't clear on like what the specific, what quote specific back pain is, and it's like when we're talking about specific back pain, typically we talk about red flag pathologies, quarter equina syndrome, spinal cord injury, ankylosing spondylitis, things that are basically what I would call medically serious, conditions where you should be at a doctor or the emergency room or that type of thing. But I think we often in the Pilates world get confused with, I guess, what I would consider more kind of garden variety findings, things like disc degeneration and, disc bulge or arthritis and things like that people find in their scans that then often we think of those as a specific cause of back pain. So, yeah, can you just kind of set the record straight on that for us, please?
Yeah, so as you're saying, you're talking about serious causes there: malignancy, fractures, the inflammatory processes that we see, all those things that you mentioned before. Then we've also got kind of more specific pathology, which can be, so the whole, it gets a bit confusing once you start getting imaging in place as well, because there are so many red herrings, but there are certain findings that do relate more strongly to pain than others. So one example would be a nerve compression. So that's certainly something that I look for quite soon, or I'm kind of looking for on a scan. Is there any nerve compression or not? The other thing is if there's multi-level changes. So if there's significant multi-level changes, so Anne Smith led some research out of Curtin University here that looked at the RAIN cohort, a large pregnancy cohort, that did MRIs on people when they were 22, and then also looked at the likelihood that they would have pain at, I think it was 27 or late 20s or early 30s. And if you have multi-level changes, then you are at increased risk of experiencing pain, as you get older. The most commonly sort of cited things or cited research is a paper by Brinjikji in 2015 that effectively it was a systematic review that looked at all the imaging findings in people without pain and found that, a really high percentage of people have got these quite scary sounding findings like disc degeneration and disc bulging on a scan when they don't have any pain. So, 37% of 20-year-olds have disc degeneration, 30% of 20-year-olds also have disc bulging. And that number increases as you get older. 96% of 80-year-olds have disc degeneration and 84% of 80-year-olds have disc bulging. So we sort of see these findings as being like, well, I'm not quite sure if that's absolutely relevant in your case, because there's such a high percentage of people that have got these symptoms as well. Now, Brinjikji also published another paper in 2015 that showed that if you have these findings, you are more likely to have pain, but it's not an absolute you are going to have pain. And as we know that there's such a high percentage of people that have got these findings and don't have pain. So I think we need to take them with a grain of salt in terms of what actually is relevant here and things, to simplify it, and there's always a risk of that. But if we were to try and simplify it, I'd be looking at things like nerve compression and multi-level changes and advanced changes as being, these might be relevant in this case. But I wouldn't necessarily view them as a death sentence, because I'm sure that within those people, they have days where they're good and they're bad. And if we did a scan on when they were good and when they were bad, we probably wouldn't see that much difference on their scan, but their symptoms are different. Okay, so why are their symptoms different? Well, maybe they had some better sleep that day. Maybe they were exercising and moving more. Maybe they had high stress on a bad pain day. They're the usual kind of things that we hear. I think the other kind of consideration in that space is how reliable MRI reports are. So there was an interesting study that Roger Herzog did in 2017 where he sent the same patient had back and leg pain, sent the same patient to 10 different MRI centres in the space of 2 weeks, just to see how consistent are the findings from different MRI centres and reports. and they found 49 different findings across all of the 10 centers, and 16 were unique and only found in one of the findings in one of the reports. And there was not a single finding that were found in all 10 of the MRI reports. So not one single finding was consistent. There was a few findings that were found across like 8 or 9 of them, but not a single finding across all 10. And then compared to the gold standard authors that they used, which were spinal surgeons and expert spinal radiographers, the radiologists averaged 12 errors. Now, if I've got good rapport with a patient and they're worried about their disc bulge, I might have a laugh with them and say, well, maybe if you're worried about your disc bulge, maybe just go to another MRI center, a different one, and you might not have the disc bulge. And that's a very measured conversation that you might have to have, because, I mean, obviously people, when they're told these things, it's quite a scary thing. And as we know, they absolutely can be a big part of why someone's got pain. But I wouldn't necessarily say that they're a death sentence. And I also, things change over time. We know that 83% of large disc herniations resorb within a few years. And so the garden today isn't the same as the garden in 2 years' time. And depending on all the things that we do to either, kill the trees in the garden or to nourish the trees in the garden, they will influence how that garden looks in a few years' time. And we know that runners have healthier discs than non-runners. People that go through weightlifting programs have healthier bodies. And it kind of speaks to one of the points you made earlier, Raf, around this idea that the human body is like a machine, and the more we use it, the more it wears out. When in actual fact, that's not true. And I think we can see that easily from the muscular perspective and the skeletal perspective. If we want to get bigger biceps, we have to load our biceps progressively. And if we do too much of that, then they're not going to, we'll tear them and they'll get injured, but they'll get better. But if we do it progressively and gradually, they'll get bigger and stronger. If we're disrupting our sleep and when we're not nourishing our body, then it's going to take longer and it's going to be harder. We know that astronauts have really poor bone mineral density when they come back from space because they haven't loaded their bones. We know that runners have healthier cartilage than non-runners and healthier bone mineral density than non-runners. Disc is cartilage. It does take longer to adapt, but it can adapt, and we know that it does adapt. I think there's a number of different considerations when it comes to this. I think the twin study by Batty was quite an interesting study that sort of helped clarify this for me. So maybe I'll quickly touch bases on that if you like.
Yeah.
Yeah, so that one way that we can figure out, is it, I suppose, load on the system or, is it nature or nurture, is look at twins, because they've got the same genetics, not the same epigenetics necessarily, but the same genetics. And this study looked at a bunch of twins, and they specifically looked at twins that had very different careers. So one was very physical and one was very sedentary. And what they thought they'd find is, the ones that the manual labourers, the brickies that are out there doing heavy lifting and loading, they're going to have, their back's going to be wrecked. And they're going to have worse looking scans. But there wasn't a clear relationship. And the authors actually said there was a trend that those more manual professionals had healthier looking discs, more hydrated discs, and healthier looking spines than their kind of more sedentary counterparts, which again, to me, just sort of solidified this idea that, stuff's adaptable, stuff can change, and we need that right environment for that.
So there's a lot in there, and those two Brinjikshi studies I think are very intriguing because they say he found that both those common findings like disc bulge, disc degeneration are super common in pain-free people at all ages and increasing across the lifespan.
Correct.
And that they're more common in people with low back pain.
Yes.
And like you say, so people with low back pain, they have often good days and bad days, and it's like, well, did your disc get better for a day and now it got worse again? That's unlikely. So there must be other factors involved. And why do so many people not have pain when they've got disc degeneration, but then some people do have pain when they don't have disc degeneration? And then we've got these other studies, 2017, those sort of radiofrequency denervation trials, Duke et al., and they literally burned out the nerve endings from the discs from people with, and you were saying like with spinal nerve compression. It's like these people had confirmed nerve root compression by MRI, and then they burned out the the nerve root from the disc or whatever, and it doesn't change pain. Like you've literally got no nerves in your disc and you've still got pain there.
Yep. Which I think speaks to the complexity of pain. And, I think the central theme that I've sort of come to learn, and I think I try to get across to my patients and that speaks from the research as well, is there's more to pain than damage. That's why we chose it as the kind of the tagline for the podcast, was what's this key theme that we want people to get out of this, and it's that there is more to pain than damage, or there can be, certainly, and particularly when it comes to persistent pain. And I think the easiest example I can give of this is like a headache. If I'm sure many of us have experienced that pain in our head. If we did a scan of our head, we're not going to see any damage in the head. But what are the things that predict a headache? Well, if you haven't been drinking enough water, if you've had poor sleep, if you've got tension in your neck, if you had a stressful day, if you haven't been exercising much, if you've been, loading your neck up in ways that you're not used to doing it. All these sorts of things predict pain and or predict a headache. But we're not going to see damage in your head when people have a headache, but it's still real pain. And I think the danger is probably a strong word, but we need to be cautious around invalidating people's pain experiences. The pain that people feel is always real 100% of the time. Maybe not 100% of the time. I've seen a few cases of, malignance and things like that, where people are making up pain for compensatory purposes to get workers' comp payouts, and that's a tricky space to be in. But even in that space, it's probably less frequent than we'd expect it would be. But pain's always real. If the person was just making up their pain, they'd just not make it up and they wouldn't be in your office. So I think it's important in the way that we communicate those studies and those findings to people to help make sure that we know that their pain's real, but it might not be necessarily related to their structure, or it might only be in part related to that structure. And let's focus on the things we can change that might have an influence in that person's pain. And I think a lot of that is around reframing their understanding of pain and what it is and what it isn't and what it doesn't mean.
Okay. Well, let's segue from there into, back into movement and pain, because there are lots of rules that we get told as Pilates instructors, and I'm sure physios. I'm an EP as well, so I got told a lot in uni, don't flex with disc bulge, keep neutral, activate your core, all of that stuff. And, so we have these rules, and then we try and retrain people to move, quote, better, more evenly, more symmetrically, whatever it might be. And then, sometimes we see people get better from doing this, and then sometimes not. And so, what did you studied in your systematic review? You looked at movement parameters, you looked at velocity, so speed of movement, you looked at range of motion of the spine, like flexion, and then you looked at whole spine range of motion as well. What else did you look at?
Yeah, so we looked at flexion was by far the most common parameter that was reported in the literature. So we looked at the end of range of motion of flexion, and that was usually measured like total movement, but also just measured in terms of segmental, so interlumbar flexion. So there was a couple of ways that different groups measured that, or different researchers measured that. We also measured EMG, and the most common finding was what we call the flexion relaxation response. So EMG is electromyography. So you place it's a bit of a dark science, dark art, but you place little electrical sensors that measure muscle activity or electrical impulses. All muscles are innervated by nerves, so nerves send electrical activity, and EMG measures that amount of muscle activity. And there's, the higher the EMG, the stronger the contraction. So we looked at EMG parameters. We actually wanted to look at a variety of different parameters, but we didn't really find that many. The most common was this flexion relaxation phenomenon, which is when in healthy controls or people that don't have back pain, we see that as they bend forward, if they're bending slower than gravity, their back muscles are working to slow that forward bend. But as they reach their end of range, their passive tissues hold on to their movement or their body, and the muscles, the active tissues relax and let go. And then that's the flexion relaxation phenomenon. And then when they come back up, their muscles tense again to bring them back up. And what we found, and we know in the literature, it's probably one of the most well documented, I suppose, signatures of people with back pain is this absence of flexion relaxation. And it's usually a combination of they're not moving as far, but also there's an element of apprehension of like, well, I've got to be careful and I shouldn't be bending my back, and it's painful to bend my back, and pain makes you tense as well. We also looked at sorry, you're going to say something now?
No, I don't have the literature in front of me, but I have seen studies finding, and you kind of mentioned it in your study as well, that people with back pain do move differently, by and large, to people without back pain. They move slower, they move stiffer, they bend less. Is that true?
Yeah. So maybe we'd sort of discuss that kind of summary as well, because that kind of feeds into what we did with this research as well, and what fed into my PhD. At any one single point in time, we can look at people with back pain and look at people without back pain and try to look at the differences in the way that you can look at anything, but we specifically, the question we're talking about is around how movement is different between those people. And Rob Laird's done a lot of great work in this space. There's been a number of people that have looked at this. And overall, people move slower, so their velocity is less. They move less through less range of motion. They usually move with less variability, so they're very consistent in their pattern. And they move with more tension. So that's usually that absence of flexion relaxation response. In my PhD, I also looked at a little bit of literature around postures, and that's much harder to measure because the changes are so much smaller. But we found that, there wasn't really much of a strong relationship between certain postures and pain. And then you can look at literature of that's what's called pain developers, where they look at people that develop pain versus people that don't develop pain in certain positions. And the common ones are sitting and standing. And there's this trend towards people that develop pain moving less variably. They're kind of always rigid in that one spot and having higher levels of trunk muscle, EMG, trunk muscle activity. So they hold themselves in stiffer and more tense positions and less variable positions.
And
so that's kind of the summary.
Those trunk muscles, right? The abs and the erectors and
yes,
all
correct.
of those.
Yeah. Yep. And it's usually this kind of co-contraction thing that we see. So, there's the abs are on, the back extensor muscles are on, the transverse muscles are on, all those, it's a co-contraction kind of phenomenon.
It's funny because, one of the most common things in Pilates is people are teaching people to activate their muscles to fix their back pain, but typically people with back pain activate their muscles more. Yeah,
absolutely. And I think this is one of the areas that I think we need to help support our Pilates and other health professionals to train people. Look, there's absolutely nothing wrong with tensing your core, and there's nothing wrong with having a strong core. In fact, it's important to have a strong core if you're, shoveling, working out in the garden, if you're lifting weights, all those sorts of things. You need to create an element of stiffness. But if that stiffness is on all the time, that's incredibly fatiguing for muscles. We don't think about, I've got to tense my bicep muscle all the time or my wrist muscle all the time. Muscles are not designed to tense all the time. They're designed to be on and off and on and off and have periods of rest. And if they're always on, they produce lots of lactic acid, and the muscles just are not designed to be on all the time. So I think that's an important point to discuss. And the core, like if we kind of delve into where that all came from, it was from a few studies over in New Zealand that found that the transverse abdominis was a little bit slower in firing compared to some of the other muscles in people with pain compared to people without pain. And it was on a university cohort, a small number of university students. We talk about this in episode 17. And then we thought, oh, fantastic, we found the panacea for low back pain, and it must be because people are firing, have got some delayed firing of some of their muscles in their trunk or in their core. And then that was extrapolated towards all populations. And we've since got research to really quite consistently show that people with back pain tend to hold their core on more, or brace their core more, or have more of these protective or tense or guarded postures and move their body less. So yeah, that's kind of how people move originally. And then I can't even remember what the question was. It was around my research.
Well, you looked at those movement parameters, range of motion, flexion relaxation, movement speed.
Mm.
I think you looked at a couple of others from memory as well.
Yeah.
So what did you find in the literature? And just to be clear, this is a systematic review, so you're not actually you're not actually like having participants there and measuring their movement. You're looking at a whole range. I think you looked at 27 studies.
Yeah.
That had looked at this. So what were the findings? Like which, if any, of those movement parameters were associated with when we change the movement parameter? If we get you more range of motion in spinal flexion, does that change? Does pain change correlate with that?
Yeah. So the other ones we looked at, just for clarity, was extension as well. We looked at velocity and rhythm as well. So was there any studies that looked at how people are moving in segments, or more in that first quartile of movement compared to the last quartile? And there was a couple of studies that looked at that, all for flexion.
And that's sorry to interrupt there. The rhythm, that's also refers to like how much you bend at the hip versus the spine, etc.
Yep. Lumbopelvic rhythm. Yep. Extension, lateral flexion, rotation, and then looking at all of the movements together. Some people just looked at kind of a combined score of all those movements: flexion, extension, lateral flexion, rotation. So yeah, what do we find? So as you say, this was a systematic review. So looked at all the available literature that had measures of movement at 2 time points, which we kind of alluded to before was not that frequent, but then also had measures of pain and activity limitation at those 2 time points. And we could individually look at whether there was a relationship from an individual perspective, a correlation between when that person, one of the people in those studies, improved in their movement. Was that related to an improvement in their pain or activity limitation? And we kind of termed improvement in terms of more range, faster range, moving back towards more normal and more relaxation. And yeah, we found we got down to, it was from about 3,000 studies initially, we got down to 27 studies that had all these criterias and measured them using kind of validated measures, outcome measures of movement. And that involved almost, as you say, 27 studies involving almost 3,000 participants. And out of all the times that relationships were investigated, i.e. did movement change when pain and activity limitation change, we only saw that 31% of those times was there a relationship between those two things. So most of the time, as people improved, their movement didn't actually change. Whether their pain or their activity limitation changed, we didn't actually see an improvement on average for most of those. 69% of the time, we didn't see that was related to their movement or improving or changing. Now, most of that was heavily dominated by flexion. So yeah, I think that's probably the most consistent finding that we found from that.
And you found pain was only correlated with changes in movement like 22% of the time, whereas function was a bit higher, right? 35 or something like that.
Yeah. Which initially I would have thought would be almost the other way around. And these people would have pain, and as their pain improved, that their movement actually improved as well. But actually, we found that when we measured function, or when we looked at the relationship between function changing and movement changing, that seemed to be slightly more frequent. But still, it wasn't overwhelmingly frequent. And I think, as researchers going into this, we always have our own sort of hunches around what you expect to find. And, as a junior physio, and going into this research, I was kind of thinking, well, of course, movement's related, like it has to be. But then when we did this research, it was sort of like understanding, oh, okay. So, when we start researching this, we start to see that there's a variety of different things that might be going on here, and it's not unidimensional and just related to these things.
So, 2/3 or more than 2/3 of the time, changes in pain and function don't correlate with any measurable changes in the movement parameters that we're looking at.
In this study, and I probably should preface as well that the way that we look at analysing or assessing the risk of bias in these studies, there's a number of different ways that you can measure that. The sample size, the number of, whether the assessor was blinded, a number of what kind of tools they used. That these are all part of assessing whether the research is high quality, and we can say, yeah, with our hand on our heart that, yeah, this is most likely true, or more low quality. And the way that we assessed it using what's called a Joanna Briggs Institute, so that's an institute in Adelaide that sort of helps you assess the quality of the evidence that you included. We only found low quality evidence of that. And there's another tool that you can use, the grade. So sort of a grade, it's called the grade tool, measures your how confident you can be in your findings for a systematic review. And then based on the type of question that you ask, the type of research that you've got, the consistency of the findings, so on and so forth, you upgrade or downgrade your kind of confidence in that finding as well. So overall, we can't be super confident in this finding. Yes, it was relatively large. There was 3,000 people in it. But there's a number of limitations still from this research, and part of that was, we couldn't individualize the assessment of what movement we looked at. So this kind of just looked at flexion in everyone, for example, but actually some people might not have had an issue with flexion. They might have had an issue with sitting, or an issue with lifting, or an issue with extension. And of course, if you look at flexion in those people, you're kind of not really individualizing that assessment of movement.
Right. So I just want to go back to the risk of bias here, because what you found in the study was that there was a lack of reporting of blinding of the assessors, which means that basically the people that were assessing at the end, like, okay, did your movement change or whatever, they knew, oh, this person's pain's got better, and then they're doing the assessment on whether, their movement changed. And it's very, very easy in that situation for that person to consciously or unconsciously kind of fudge the numbers a little bit. And, I've seen a famous clip on YouTube of some kind of spinal surgeon, demonstrating the movement of the scapula of this person who's got scapular dyskinesis, and then the patient says, it's the other shoulder,
Yeah. Yeah, look, we made sure that they had they used sort of objective measures to measure these things. So commonly it was sort of a 2 inclinometer method, or kind of more digital tools. So I like to think that researchers don't fudge the number, but I think it's more the unconscious biases that are present in researchers when you can't blindly measure these things. Like for example, for a pharmacological trial, you can, give it a questionnaire, and, you don't know who, you can be blinded to who has or hasn't had the intervention. But it's really quite hard in physiotherapy land, where there's exercise trials and assessors that, are an integral part of the kind of the research process. And you can also see, I think physios and people that work in Pilates would certainly know that you can kind of see when people have more pain versus not. They've got a lot of these pain communication behaviors, grimacing, breath holding, those sorts of things. You can get a bit of a sense of like what's going on for that person. Yeah. But yeah, we did find that there was quite a high risk of bias for many of those studies.
So does that mean that we just can't trust, like, the research, might be, it's just a question mark? Or is it more likely that, given that potential source of bias, that it's likely that the effect was systematically overestimated or systematically underestimated?
Yeah, it's difficult to say, but probably more, my sense would be more overestimation of the effect. If we've got these people that are not blinded to who they're assessing, then they're more likely to find a relationship, or based on it all depends on what their beliefs are as well, of course. But you probably would overestimate that effect size, or that's the strength of the relationship. But yeah, I think it's to me, it's like, well, these are the best we've got. We've looked at this question. We've got to take into consideration that there isn't that high quality literature out there. So we've got to take this into understanding from a wide lens, and see what other literature and studies are out there that can help us understand this as well, and then make a decision.
And so, all right, so with all of those considerable caveats, we found that you found that for roughly a third of people, changes in movement did correlate with changes in pain and function. and they were, I can't remember if we've talked about it, but it was like increased range of motion into flexion, increased movement speed, and increased flexion relaxation. I think they were the three
Yeah.
big ones, right?
Yep. Yeah. So I can't. Sorry, go.
Yeah, and what struck me in the research in what you in your paper was like it was almost 100% correlate. Like when there was a change in movement that correlated with pain, it was almost always like some combination of those things.
Correct. Yeah. So I suppose I wanted to understand first of all, is there a relationship when movement changes? Does pain or activity limitation change? And we answered that with that 31%. Okay, so the 31% of the time, there is this relationship between those two things. But what actually happens to movement as pain or activity limitation improves? So then we looked at like the direction or the directionality of what movement changes occurred in that 31% of the time when there was a relationship. And 93% of the time, we saw that as exactly as you said, movement range increased, movement speed increased, flexion relaxation increased. We sort of, I guess, termed that towards less protective movement. People reverted back towards more normalized, less protective movements. And I think this is the kind of the common sense narrative that most people take out of their back pain patients probably is that, yeah, when they come in, they're really stiff and tense and we do XYZ treatment for them. And then, in a few weeks time, they come back and they're moving better, faster, more normal, more, less protective. And that was kind of true, but only for 31% of the time. And like I said, I think those are the reasons that we talked about before in terms of not being able to individualize movement, was a big part of that, which kind of led to me doing another systematic review of studies where we could individualize that assessment. So that was a single case series published in the JOSPT cases that looked specifically at individual sort of level data, where the single case series where the assessment of movement could be individualized to that person. And we found that, it was 70% of the time there was a relationship. Or 71% of the time there was a relationship. So we sort of saw a big increase in that frequency of the relationship being present when we were able to individualize the assessment of movement. But still, the common finding across the two systematic reviews was that as they improved in the single case series systematic review, it was still 97% of the time that their movement became less protective. So that was a common finding across both of those.
Right. And so the way you're framing that, does kind of imply sort of the direction of causation there, that you suspect that it's the change in pain and function leads to a change in movement.
Causation's a question that researchers will jump around a lot about. So short answer is we don't have an answer on causality and the directionality of what changes first. We did a few stats with the single case series that I did where we had a bunch of people with back pain and measured these factors very frequently on a weekly basis, and then tried to see which one changed first. And there was a little bit of a trend towards movement changing first before pain and activity limitation changed. My hunch, I think, working with people through the lens of behavioral experiments and testing things and how does movement influence your pain, and if we change this, what happens to your pain? My hunch is that it's actually changing the movement, which ends up changing the pain and activity limitation, if their pain is dominantly driven by a mechanical movement related problem. Whereas if and there's, I'm pulling out numbers here, but I'd say maybe that's 80% of the population of people that I see. And there's a group of people where they've got much more dominantly driven, I suppose, psychosocial pain from, a variety of different factors, stressful life events, a sensitivity of the nervous system, more inflammatory processes, those sorts of things. But the other thing is, we can get quite deep into this, and I don't want to.
Sorry, just before we go there, I want to ask you, when you say mechanical pain, what do you mean by that?
Yeah, so I think it's the way that we sort of describe this to the students, and the way that I understand it in my head is that it's when I do this thing, I have this pain, and it's quite consistent. So when I bend my elbow, I get elbow pain. When I bend my back, I get back pain, and it's quite consistent. to me, that's kind of more movement-related style type presentation, I
Right.
suppose.
Which doesn't necessarily imply that there's a damage in the tissues that's the primary driver, but
No.
it does. There is a relationship between movement and symptom.
Yeah.
Right.
Yeah.
Okay, so this is very interesting. This is kind of like gets to the heart of what I really was hoping to sort of get to today. Is this, the direction of causality, and I understand that we don't have really any strong research one way or the other. I was on a course with Peter O'Sullivan a few years back at UQ, and the cognitive functional therapy course, and I've actually done that course a few times with him, and every time, the last time was several years ago, so maybe he's changed since then, but he was very big on extinguishing pain behaviours with people. He wouldn't let people limp or hobble or grimace or grunt or brace their core or use a walking stick or all of those kinds of things. Um, and his kind of the sense I got from what he explained about his reasoning for that is that, like, well, people have these sensitized tissues, maybe there's inflammatory, things going on, whatever, something's irritated in there. And then when they're sort of co-contracting and sort of basically increasing compressive load on those structures by bracing and protecting and whatever, and also basically increasing the threat value by these movement, protective movements that we're doing, it can kind of, it's not that limping causes you to have a sore back, but it's like if you've got a sore back and you protect, that can kind of cause a bit of a positive feedback loop and exacerbate the cycle. So is that kind of what you mean when you say, those protective behaviours seem to change a little before the pain changes?
Yeah, I think, I mean, I can only speak from my experiences and my thoughts and perspectives on this as well. And I think I'll probably lean on the final paper of my PhD, which was published in the European Journal of Pain, From Protection to Non-Protection, where it was a mixed methods paper. And I interviewed people before they had CFT. And CFT, cognitive functional therapy, for those that don't know, it's one method that people can use to help people with low back pain or any sort of musculoskeletal pain. We alluded to before that most of the effect sizes are very small for treatments and often not sustaining. CFT has shown in a large randomized controlled trial published in The Lancet, a very prestigious medical journal, that there is large and sustained effect sizes for people with back pain. And there's a couple of other treatments out there. Pain reprocessing therapy comes to mind as well. That has some, high quality evidence, randomized controlled trial evidence of effectiveness. But effectively, the participants in my PhD went through cognitive functional therapy. They received cognitive functional therapy, and a big part of what we did with these people what I did with these people was interview them before and after. I wasn't the treating clinician, but I interviewed them before and after, and I measured their movements and postures and a whole bunch of thoughts and emotions and feelings and pain and activity limitation before and after, but also very repeatedly throughout the whole process. And we've had these common themes of people talking about, they felt very stiff in their movements. They protected themselves. They were guarded. They were careful. They felt restricted, tense, locked up. And we've dubbed that what we call non-conscious protection. It's this sort of the body and the nervous system protecting usually a perceived vulnerable structure, or what they've been told is a damaged or injured vulnerable structure or painful structure, but doing it subconsciously. So not being aware of it. But then we also had a group of people that said, oh, no, I'm very careful with my back. I consciously brace my core. I consciously tense. I consciously avoid. I'm very careful and cautious with my movements, which we've sort of dubbed more conscious protection. So you have this non-conscious and conscious protection group before the intervention. And that was corroborated by the movements that we measured. They were all, the typical things we've talked about: slow, more tense on average, not everyone, but more tense. Lacked flexion relaxation, less range of motion. We sort of saw that being corroborated in the quantitative data from the sensors as well. And then after they got better, they talked about, like I had to learn to relax and move more normally and breathe and trust my body again. And initially I had to consciously think about not protecting as much and consciously think about doing that. So we sort of dubbed conscious non-protection. But most people kind of had to initially focus on that, and then that became automatic and habitual again. They progressed towards non-conscious non-protection, so forgetting about their back again. And that kind of journey was quite well supported by the movement postural data, as well as the pain and function and sort of psychological factors. So we saw this whole schema shift of a variety of things, from moving from protection, or I've got to be careful with the way that I move because of my perceived damage structures, towards, it's actually safe to move. And a big part of that, which is the important point that I'm getting to here, is that a big part of that came through what we call the behavioral experiments. So in usually the first few treatment sessions with the clinician, the clinician looked and assessed their movements and postures, and then they invited them to do things in a different way. So they picked up all the pain behaviors that you mentioned and just checked whether that was useful and helpful, and what would happen if people didn't do that, and if they were trained and taught to move in less protective ways, what actually happened to their pain. And we found for a lot of these people, their pain would significantly reduce or sometimes go away. And I think that was one of the key things that I took out of, I think it might have even been the same Peter O'Sullivan course in UQ a few years ago, was that, geez, wow, people's pain's like very modifiable in that right environment. For people that have had pain for years, bending and sitting, their pain can be can be changed quite quickly. And usually that comes through a change in their movement, kind of sort of shaking or perturbing their system, and they've kind of subconsciously and consciously adopted all these protective behaviors. And then when they don't do that, or they're coached not to do that by a skilled clinician, and then we assess what impact does that have on you, it's kind of, we run experiments. Oh, that actually feels way better. Or yeah, I don't have that kind of tight, pinchy feeling in my back, and I can move a bit further. Oh, okay. So what does that tell you around what's causing your pain? Like, is it the disc that you're worried about, or is it the way that your body's moving around that perceived, damaged disc? Oh, okay. And then so people start having these kind of unravelations, I suppose, of what they think is causing their pain, and then they end up developing a lot of self-efficacy and confidence in their body through these exposure processes, and realizing, hey, the belief and the worry of like, my back's damaged, it's going to get worse as I get older, that drives these behavioral responses of protection, of tension, of tightness, but they don't have any strategies to change them. And when they're taught to change them, their pain can quite often, and in most people, it reduces, and then their nervous system recalibrates what they thought, and it's a far less threatening narrative as well, what they thought was initially causing their pain. Long answer.
No, amazing. Maybe it was the same course at UQ. So what I heard there, I think, was basically, when you have somebody with low back pain and they're moving stiff and protecting themselves and grimacing and grunting and putting their hand on their knee when they go to sit on a chair and stuff like that, behavioral experiments might be like just inviting them, to see if they'd be open to, would you be open to exploring, like not tensing your abs as you stand up out of the chair or bend forwards or whatever, would you be open to taking a deep belly breath in and just slumping in your chair a bit and then see, how's your back feel now? And, it feels better. What do you make of that? Is that what you mean?
Yeah, exactly. And I think we, as clinicians, and I'm not CFT trained, I should say as well. They use CFT throughout my PhD, but I haven't gone into depth into learning these strategies. And there's some great resources which we can share. So Evolve Pain Academy is doing a lot of this sort of training as well. But the kind of the crux of that whole process, it starts with a very clear subjective examination, and this all occurs in the absence of the red flag pathology, and the specific pathology we talked about earlier. It starts with a very clear subjective examination, and often in that you kind of can start to hear discrepancies in people's stories. One of the participants in my PhD, participant 6 actually, talked about, because I asked her all about movement and posture and how that influences her pain. She's like, oh yeah, like I slouch in my chair and it feels better, but I never do that because I need to sit up straight. So often people have these they hold two discordant kind of beliefs, and your experience usually triumphs your belief triumphs your experience. So that the belief of like, I've got to maintain better posture, even though it's more painful for me, is more important because I need to protect myself in the future. So people have these kind of discrepancies that you can often pick up in people's stories, or you might ask about easing factors, or what makes your pain better? Oh yeah, actually usually when when I can lay down. Tell me why that feels better. Oh, I just feel like my back just lets go and relaxes. Oh, okay. What do you feel when you're moving? Generally speaking, yeah, I just feel this kind of tightness in my back. I feel everything's really, really guarded and tense as I'm moving, and then you can observe that as well. You assess that. But yeah, I mean, the short answer to your question is yes. It's those kind of functional behaviors. You can kind of set them up, not in a manipulative way, but you can start to get a bit of a picture and start sowing a few seeds that, okay, there's a bit more to pain than just your damaged discs, and there's potentially there's strategies that your body's doing, which may have been really helpful strategies in the acute injury event that happened 5 or 10 years ago or 1 year ago, but now maintaining them is now contributing and a big driver of your pain. And the example we use quite often, or Pete uses quite often as well, is the wrist, right? Like if you sprain your wrist, and it's pretty normal to be a bit protective of that, like a bird that protects its wing, you kind of tense it, you keep it close, you don't move it much. But then you want the wrist will recover because it's a living, breathing tissue. And if you gradually move it, it's going to get better. But if you're always clenching it and tensing it and never moving it, it can maintain this sort of sensitized state through local tissue loading, increases in inflammatory processes, different schemas of the way the nervous system interprets information from that area, a variety of different factors that can contribute to that, the experience of pain. But yeah, those behavioral experiments can be really, really powerful to just test whether your strategy, A, whether you're aware of it, and B, whether it's still warranted, whether it's still helpful. And if it's not helpful, then we need to detrain you from that.
So, in terms of a takeaway for listeners, most of whom I think are probably Pilates instructors. There might be some physios and EPs, personal trainers, yoga instructors out there, but by and large, Pilates instructors, I guess, level one, encouraging our clients to move through the largest, range of motion, be as relaxed as possible, move fast, not worry, not be too conscious about their low back movement. And level two, behavioral experiments of like, okay, well, what would happen if you slumped, or what would happen if you, breathed into your belly and didn't tense your abs, et cetera. And then what do you make of that, and having a conversation around their experience?
Yeah, I think that's a helpful kind of questions for people to ask themselves. I mean, end of the day, Pilates instructors are trained health professionals. They know a lot about the body, and I think we can rely on our levels of confidence with that. And I think building rapport is such an important part of what we as health professionals do. I would just say that movement is one aspect of a variety of different things that influence a person's pain. And the more vigilant we are about movement, I think that can be an unhelpful thing for that 25% of people that end up having, issues. For the majority of people that Pilates instructors would see, I suspect they'd be totally fine and that strategy is great, no worries. But there's a group of people that end up having persisting or disabling pain presentations that can have where those narratives can be unhelpful for people in terms of bracing and tensing and sucking your belly in, because it produces this sort of schema of your back is vulnerable. You've got to be careful with it. It's fragile, which increases the threat value of any information that's sensed in that area from the nervous system. So I would say for those people, it's about gradually re-exposing them to all sorts of different movements and postures and building up the sense of safety and the sense of confidence in their structures. And that might be initially starting with some, people often feel a bit safer if they've got a bit of co-contraction. And maybe that's a place where you start, but it's not, it's not the end goal. I think the end goal is something Louis Gifford talked about, this sort of fearless, thoughtless movement and getting back towards forgetting about your back, forgetting sort of normality. I think one of the discharge criteria for my patients, you've got Louis Gifford's book there. One of my discharge criteria for my patients is, have you forgotten that your back exists? Yes, of course, we've got to be sensible, but really the end goal is that you get to a stage where you don't have to think about your back. You don't have to think about bracing this and tensing that before you move, because that is not normal. And if we think about, how long humans have been around for, I mean, the Aboriginal culture is the longest surviving culture, as we know, 65,000 years. Homo erectus, Homo sapiens, been around for 200,000 to 2 million years. How long's Pilates been around for? I mean, Joseph published his first book about 90 years ago. Yep, 100 years or so. If we think about, that's like a tiny percentage of how long humans have been around for. And I think if we can get to a stage where we're instilling confidence back into people and building their self-efficacy and their ability to do the things that bring them value without having undue worry about their back, that's a really good place to be. So that's kind of my level one, and maybe the level two would be experimenting with what actually feels, and you can ask the patient, what actually feels better for you when, what are your goals? How can we facilitate you getting towards your goals? And experimenting with different movements. Tension's not the devil, and relaxation's probably not the devil either. I think they can all kind of coexist, and we've got to figure out what works well for you and the strategies that work well for you, with this overarching theme of moving towards movements and postures that are natural, normal, more fluid, where you don't have to think about them, and can gradually nourish the structures of your body and get you back to health and doing the things that you value.
Great. I just want to double click on, I think, two of those terms that you just used there, because I think a lot of times we use the same word and we mean different things by it.
Yep.
You said, and I feel pretty confident in what you meant there, but I just want to make sure that we're sending out a very clear message to people.
Yeah.
You said people, I think, fostering a sense of safety in their body. And I think, paradoxically, a lot of the time when movement professionals are very, concerned about the safety of their clients, that can come across in a way that it's like the helicopter mum who is like, "Oh, darling, don't touch that. Yeah. And it actually kind of makes the person more tense and fearful without us meaning to. I've used a story before of I used to be a nervous flyer, and when I would be hitting a bit of turbulence, I look around and there's a cabin crew. If they're kind of laughing and joking and pouring the coffee, I'm like, oh, this must be normal. But if they're kind of freaking out and, then I'm like, oh crap, I need to be worried about this. So I think, like you said before, patients get their beliefs from clinicians a lot of the time, and those can be unconsciously transmitted, even if we're never saying your back is broken and you've got the back of a 90-year-old. If we're very basically anxious and over solicitous, that can not foster a sense of safety, even though we're saying, let's keep you safe by not doing this movement or whatever.
Yeah.
Yeah. So
I think it's a really important point to double click on, and maybe I'll kind of sort of come off the back of that as well. I think as we sort of discussed at the start of this conversation, we're well-meaning professionals. We care about our patients, and yes, we don't like to see them in pain unnecessarily. So we'll naturally err on the side of caution, of whatever we think caution is. But I think that can be unhelpful in certain populations, because it does foster this narrative of if you're not careful, you're going to, damage your back and you're going to end up in a wheelchair. A lot of these unhelpful myths that people have. And I think that does that in sort of two different ways that probably are quite interconnected. But one is that I think if we understand the common sense model of illness behavior, which is a model from Leventhal, which basically says we've got our experience, we've got our thoughts, we've got our emotions, and then we've got our actions based on that whole process. And then we appraise whether that action was helpful or not. So if we're thinking, oh crap, we've got to be really careful from our back because of whatever we've been told, that instills fear, that protective, the response or the action from that might be to avoid or to protect and tense. That can drive more pain through all the processes we've talked about. We reappraise that, and then we're kind of in that sort of, nothing's getting better, and you're kind of in a bit of a negative spiral. I think the other way that's unhelpful is it can trigger the nervous system to be in more of a sensitized or threat sensing state, because we've been told, we've got to be careful with our back. So our nervous systems kind of skewed towards seeing danger. And our nervous system is always geared to see danger. That's evolutionary, very protective. We've got these automatic negative thoughts and automatic processes that keep us safe, or traditionally have kept us safe in the savannah. But our nervous system's the more we skew it towards looking for danger and looking for threats, and then the more we experience that, the more the nervous system intensifies signals coming from the periphery, and the more that amplifies the system. The example I kind of use sometimes is like when if you listen quietly, you might be able to hear air conditioning, or if you think about it, you can feel the way that your foot's making contact with the ground. Now, if we would have actually measured those things 5 minutes ago, the decibels of the aircon would be exactly the same as they are now, and the pressure of our foot in the ground would be exactly the same as it is now, but we weren't conscious of those because our nervous system kind of had this low level of, well, everything's normal, we don't have to alert you. But the more you pay attention to it and the more threatening that might be, actual or perceived, the more our nervous system will amplify or intensify signals from that area as a way to try and protect us. So yeah, well-meaning, but can be a little bit unhelpful, I think, for some people. Like I said, for most people, they'll kind of coast through life and be no worries, and they're using Pilates as a way to feel strong and confident in their body, and I love that. I think it's a really good way to do that. But for a certain population, it can result in unnecessary or undue fear and worry and increased threat and the protective or kind of actions as a result of those things as well.
That's one of the biggest things I took from Peter O'Sullivan's trainings. When I went to that training, I think I'd pretty much read everything he'd written, even the early core activation papers he did in 2005 and stuff. And at the start of the course, he said, I'm going to challenge all your preconceptions and blow your mind. I was like, I don't think so. I've read everything you've written. I know what you're going to say. And then 5 minutes later, it felt like he said, I think it's totally safe to heavy deadlift with a flexed spine. I was like, no. So I think that, so the big takeaway for me, or one of the big takeaways for me from all of what I've read of his work and worked with him on those courses has been, be fearless yourself. And I think as a practitioner, and also there's that study, I always forget the name of it. And my friend Brendan Mowat always sent it to me because it's part of his PhD thesis. But there was a study of dentists, this is in the 80s.
Yeah. With the pain, the opioid medication.
Right, and they were, half of them were giving a placebo and half of them were not giving a placebo, and they were told, "Oh, you're giving a placebo, you're not giving a placebo." Only thing is, they were all giving a placebo.
Yeah.
And the dentist was told, "You're giving a placebo, but don't let the patient know." But the dentists who were told that, the placebo didn't work as well. So somehow, even though the dentist tried to, fool the patients, they communicated it somehow unconsciously.
Yeah.
And so I think, for me, a really powerful lesson from all of this has been you have to genuinely cultivate fearlessness in yourself as a practitioner, because you are the cabin crew in this situation. You are the dentist in this situation. If the patient looks at you and they see, even if you're smiling and nodding, if underneath you're kind of freaking out, it's that will communicate itself somehow, and fear is catching.
Totally. Yep, absolutely. A lot of that communication is subconscious.
The other thing I want to double click on is what you said about normalizing movement, or returning to a more, I can't remember the other word, but basically normal
less
movement.
Protective, normalized.
Yeah, more normal movement pattern. And I want to really again kind of get explicit with this, because one thing we do in Pilates a lot is we retrain people how to move, quote, more normally, as in with better glute activation and more symmetrical VMO, recruitment and pelvis aligned correctly and whatever. And so I'm assuming that's not what you were talking about. You were talking about the Louis Gifford style of normal movement, which is fearless, thoughtless movement, where you literally don't think about it at all. And it's that's when you get better from a sore throat or a sore back or a sore tooth. It's how you're better is you realize oh crap, I haven't thought about my tooth for a week.
Yeah.
It's that's what being better is is you're just not aware of that body part. It's just doing its thing.
Yep. I agree.
So when you say normal movement, what do you mean?
Yeah, so and I think this this kind of talks a little bit about what, or there's sort of two threads of mine that, or you've kind of talked a little bit about that I think are worthwhile clarifying or talking about on this point. One is this idea of humans have been around for a really bloody long time, and normal movement has been normal movement for much longer than the kind of the ways that we have trained people. I think over the last 0.014% of time that humans have been around for. So when I say normal movement, I mean the 99.2% of time, not the 0.14% of time where we've been, I think, probably pathologizing normality and calling things out. And we've, well-intentioned, we've found a few studies that showed a few things, and then we've extrapolated from that. But actually, in actual fact, we haven't seen the other 90% of the population that never have issues and they've got misfiring glutes or whatever it ends up being. And to think that the human body would have evolved over 65,000 plus years and not been able to fire those things appropriately from a subconscious level, to me, I think is a little bit reductionist and doesn't actually give the human body credit for what's going on. And we know the pain inhibits these things as well. So are we seeing just, the downstream consequences, not a cause of that as well? So that when I say normal, I'm much more referring towards, Louis Gifford's style of thoughtless, fearless movement and that type of movement of that we've described. The other thing that comes to mind that I find quite interesting, so two of the models from my PhD, I think it can be unbiased, obviously, but I think it's quite useful to understand this journey, and that is that sort of protection to non-protection model that we initially described, which is a little bit like the conscious competence model. So first, you're completely not conscious that you're incompetent at a skill, and then you're aware that you're incompetent at the skill, and then you have to really work on the skill and consciously practice that skill. And then eventually you do that skill automatically and you become consciously competent at it. So that's, I think, that kind of protection to non-protection journey. The second thing that kind of came out of this was this, I called it the carefree movement continuum. We sort of started, it was actually more of a spectrum, I suppose. We started before we ever got back pain. And, if we're just hanging around there in world, we never think about our back. We might, that's not necessarily 100% of the truth. There is quite negative beliefs out there in society, even if you haven't had back pain, but we're not really thinking about it much. And then we have back pain, and our carefree movement goes towards being very careful and cautious movement. And that's driven by, societal messages, pain, health professionals, a variety of different things. And we adopt these strategies, which might be really helpful if we've had a traumatic injury, and that's a good thing. But then I think if they continue on for too long, then they become unhelpful. But the journey of getting back out from that kind of conundrum is to return back towards your previous carefree movement continuum. And that's what we saw in the literature as well, is as these people got better, they reverted back towards these more carefree things. So you start carefree, you get careful as a result of pain, injury, messages, etc., etc. And to get out of that, I think a big part of it is to become carefree again. Now, that's a pretty complex journey for lots of different people, and some people might never get there. But I think and maybe it's a little bit simplistic as well, but that's kind of the summary of my journey of my PhD, I would say, and the way that I think about pain in this and back pain in this more zoomed out perspective.
I love that, Kevin. I think it's deceptively rich and deep. That this one systematic review that we started talking about with the flexion and flexion relaxation and those parameters, which is a very biomechanical based sort of analysis, found that sometimes those things do correlate with changes in pain and function. But our broader discussion and what you said about CFT and the biopsychosocial contributor, model of pain, this change to more carefree movement correlates with improvements in pain and function a lot more, because it's not just the change in the movement, it's the change in all of the other things that go into that carefree. And probably when you're moving more carefree, you probably are bending further and probably are relaxing more. And that's so it's the mechanical constructs that you measured in this systematic review, they are true probably, but they're probably more a result of or a part of a bigger picture rather than, truly a target of, look, we must stretch people into more spinal flexion in order to improve their back pain.
Yep. Yes, it's this complex multidimensional schema shift, we called it in my PhD and in that paper. From this, I've got a damaged back or I've got to protect my damaged back towards it's safe to move again. And you're right. I think belief drives behavior. So if what we're thinking has quite a big influence on the way that we behave and the way that we do these things. So, but it's also changing behavior and changing pain with movement is a really good way to recalibrate those beliefs. And I think, one of the dangers here is to just tell people, oh yeah, no worries, just bend, move, you'll be fine. And I think it's just not that simple. I mean, people don't argue with their own data. So I think helping people to explore and find out what are the things that are helpful for them is an important part of that behavioral experiment process. So yeah, we're sort of using movement as a strategy to recalibrate the system if what we find, is that it's more helpful and less painful to do it in a more relaxed way. Now, that is just one strategy. There's more psychological driven strategies that you can do to kind of recalibrate the safety system or the protection system. There's other interventions, and I think this is kind of one of the common mechanisms of how people get better is what we call safety learning. It's this process of learning your body's safe, and that can happen through surgery, that can happen through injections, it can happen through ayahuasca, and all these sorts of variety of different interventions. But I think the key premise is it's sort of a recalibrating of your nervous system that, it's actually my body is safe.
I would say, yes, it can happen through all of those things, but we have this, we have data showing that the effect of exercise on low back pain is not greater than placebo. And the same for surgery, same for, opioids, long term. And, some very promising trials of CFT showing that it has a greater effect. So I don't think you can put this into the same bucket as all of those other things.
No, and I think I would agree with that. And I think it's the fact that it's kind of integrated and holistic is probably one of the key differentiators there. Surgery just looks at one thing, or injections just look at one thing. It's unidimensional treatment or dimensional approach. But whereas this is a bit more of a whole person, whole system integrated approach.
What a great place to leave it. This has been fantastic. If there's any one thing you'd like to sort of shout from the treetops, to finish with, is there anything we've missed?
No, probably the main thing would be nothing that I think we've missed, but the main thing would be foster safety in movement, or foster safety or safe experience in people, and progressively get them back to doing things that they love as part of that.
From careful movement to careless movement.
Yep. Sounds good.
Great. Thanks, Kevin.
Much easier said than done.
Well, otherwise there'd be no jobs for us.
Exactly.